So I'm going to talk about accelerated resolution therapy today. My day job is I do telehealth for a company called Talkiatry, which is a mainland-based company, and so I do traditional psychiatric practice there. But the last appointment of every day, I try to leave free so that I can do a longer session of ART if I need to. Okay, next slide. So the one main disclosure I have is that I am a certified ART trainer, and so as in that role, I am paid to do trainings by the host organization, which is called Rosenzweig Center for Rapid Recovery. Lainey Rosenzweig developed ART, and this is her company, and it's the only official source of ART training in the world, as far as I'm aware. There are some slides at the end. I just want to kind of mention that they have like the cost of trainings and how to set up training, and I'm really agnostic about that. I mean, I have, again, a day job, so the training is something I like to do when I have some time, but I'm not here to advertise ART or ART training, but I know that those types of questions come up about how to get trained and how much it costs, so that's why I decided to add them to the slide deck. Okay, next. So these are some learning objectives I thought you might want to take home from the talk today. So first one is to be able to describe 3 ways in which ART is different from traditional trauma-focused therapies. Another one is to describe the memory reconsolidation process in general terms, which could apply to more than just ART. And then 3, to be able to name 3 psychiatric disorders that are likely to benefit from ART. Okay, next. I'm going to go through these in a second, but I wanted to mention, since I know we have some non-mental health providers on the call, in order to be trained in ART, you have to be a licensed mental health provider or a pre-licensed provider who is able to participate under supervision and is working toward a license. People like family medicine, chaplains, OT, they're not eligible for training, but there is something called safety, which is a one-day training. It's kind of like ART light and is really helpful in allowing people to learn how to use eye movements to move sensations and help resolve distress. So I can talk more about that if you need me to in the Q&A. So ART is an efficient, directive, and procedural eye movement-based therapy rooted in EMDR. So the founder, Lainey, was trained in EMDR, and she was participating in her supervision call. And she was explaining what she was doing and the awesome results she was getting. And her supervisor said, well, that's great, but you're not doing EMDR. So whatever you're doing is something different. You can either call it something else, or you can get back on board and, do the protocol that we taught you in your EMDR training. And she felt like she was getting such good results that she wanted to stick with what she was doing. So she called it ART. ART desensitizes patients to troubling sensations and cognitions that are associated with things like PTSD, grief, panic, OCD, and many other psychiatric conditions. Basically, any kind of psychiatric condition that is associated with negative images, negative memories, or feelings, sensations can be tackled with ART. So the process involves re-scripting disturbing memories and fears so that you kind of decouple those memories from their emotional tone. And I'll talk a little bit more about that in a second. It does naturally facilitate cognitive restructuring and meaning making, meaning that you can achieve some of the same outcomes that you would from something like CBT or CPT, but much more easily and naturally without having to think too hard about it or do homework assignments. The therapist does not need to prepare for the session. In their basic training, they learn the standard ART protocol, and then once they've learned that protocol, they can, as we say, art anything. So you don't have to remember what session you're on. You don't have to, Xerox or that's probably an old term now. You don't have to copy the worksheets. You really don't have to prepare, which is nice. Additionally, there's no homework required for the patient. They just come in, they do their session, they go away. There's nothing they have to do in between sessions. They don't even need to disclose the details of their trauma. And that's one of the big differences between ART and other trauma-focused therapies, is the therapist can actually do an entire session without even knowing what the client or patient is working on. And I've done a couple of those in my career, and it's amazing how well it works. Finally, each session is a standalone intervention, meaning that, I don't have to make sure that I see this individual at 10 a.m. every Tuesday morning for 8 weeks. I can do a session and they can go traveling for 3 weeks and come back, and I can do another session. I can do them frequently. I can do them infrequently. So it's very, very convenient for populations that might have to move a lot or deploy a lot, such as the military, or they're traveling. So it's really convenient that way. Next slide. Okay, I'm not allowed to share the specific protocol because it is proprietary. There's some intellectual property, and I've signed a non-disclosure agreement. But a general overview of the process is that what we want to do in an ART session is activate the memory, meaning like get it, in the front of the individual's consciousness, so they're really remembering it very, very accurately, or at least very emotionally. Okay, next. And then we do some imaginal exposure and desensitization. So, in a lot of trauma-focused therapies, the exposure is verbal, or, it's narrative, or it's written, or you're using sand tables or something to kind of talk through that trauma. But in ART, it's all done in the patient's mind. And as a consequence of looking at that a few times in their mind, like a movie, then they're desensitized to the trauma. But we don't want them to continue doing it to where they're completely extinguished. We want to retain some of that feeling, because those emotions and feelings are what we're going to work with in order to accomplish the benefit. Okay, next. Then there's a rescripting piece. And the rescripting is kind of specific with ART in the sense that you're not looking to just, change it back to the way it was or come up with something neutral. You actually want it to be very positive. And I'll show you some slides in a few minutes about that. Oh, I guess I just talked about it. Okay, then there's some positive visualization beyond the rescripting to kind of really enhance and solidify the changes that they're making in their memory. And next. And finally, there's some elements of closure so that by the time they leave your office, things should be fairly well packaged. Very rarely will you have to kind of box something up and put it on the shelf like you might with EMDR or some other therapies. Most of the time, you're able to complete everything that you were working on during the session. Next. So I made this little graph to try and just highlight in very simplistic terms how ART is different from a lot of trauma-focused therapies. So for most therapies, you want to decrease distress over time. So the longer they're in treatment, the more their distress is going to decrease. Next. And you certainly want to do that with ART as well, but you also will be increasing hope and joy. And not only is that great for the session, but that seems to contribute to greater resilience, greater confidence, and generalization of the benefits of one session to a broader portion of their life and better functioning overall. Okay, next. So to kind of highlight how the memory consolidation and reconsolidation process works, I've come up with this graphic because I think it's really important for everyone on this call to understand this process, even if they don't ever do ART. So someone would be exposed to a traumatic experience, for example, a dog bite. They get bit by a vicious dog. That memory is very raw. I think of it as like those snow globes that you shake up, and all the bits of that memory are kind of floating around, and they gradually kind of sift down over time. And even at the bottom, they're not fully solidified, but at least they're next. And so as that memory consolidates, you'll get kind of longer term storage of that memory. It'll still be there, but it'll be maybe tucked away under some other things and harder to access. Next. So let's say that individual that was bit by a dog in the past encounters another dog, pleasant dog. This is a nice looking dog, a dog that wouldn't, panic most people, but because they had this dog bite in the past, next, they're going to imagine, or at least they're going to be triggered as if they were encountering that same scary dog that they had encountered in the past. So that that memory of the scary dog is reactivated. It's made unstable. And if a memory in its activated state, or when it's in its activated state, it's unstable and subject to modification. And we know that from bench science research. Next. So if you do nothing, you just kind of, walk away from the dog, try and calm down. Maybe you do some, yoga, or, just relax. That memory is going to reconsolidate in somewhere between 0 and 6 hours. So if you do nothing, it'll kind of get tucked away, probably the same as it was before, maybe a little more vibrant, but, nothing's really changed about it. Next. In traditional therapy, like CPT, prolonged exposure, those types of things, we do want to decrease that distress and hopefully get to the point where that memory is kind of, neutralized. It's tucked away as a more benign dog, so that hopefully when the individual encounters a benign dog, that benign dog memory will come up and they won't be activated in the way that they were before. But what we do know about some of those things is that those types of improved memories can decay. So we want to do one better with ART. And next. So with ART, we want a happy, joyful dog. We want a dog that wants to play with you, that's licking you, that's really, running around circles, making you laugh. We want that individual to be thinking about a fun time when they encounter a dog. So next slide. This is kind of a very simplistic schematic of what I just talked about. So, normally if an individual is bit by a dog, this is on the far left is how they'll imagine dogs before they get any therapy. In the middle is kind of how they might imagine a dog after they've gotten some trauma-focused therapy. It doesn't bother them anymore. It's just kind of there. But after ART, an individual will really be happy about dogs, and they'll imagine happy, playful dogs. And the reason that this seems to happen is that we've created this expectation mismatch, or predictive error, as it's called sometimes in literature. And basically that just means that when we have a client or a patient thinking about a scary negative memory, but we can change the valence of their affect or their emotions, meaning we can have them feel maybe even beyond relaxed, but happy or joyful, then that's going to be the emotion that's now attached to that memory. And the memory becomes much less significant. A lot of times it just fades into the background. It's harder for them to pull up, or it becomes just like, any other memory in their life, like what they had for breakfast yesterday, maybe hard to even think about. Next. Another example from the military environment, before any therapy, an individual might recall his buddy, being killed or wounded in action. They remember the event the way that it happened. After traditional trauma-focused therapy, they might remember their buddy, strong, proud, just kind of standing there ready and able to do their job. But after ART, they're going to think about the most positive time they had with their buddy, or maybe even something they never got to experience with their buddy. They're going to think about how their buddy would prefer to be remembered, and the way that they could have fun together and just have a great, positive emotion come up when they think about their lost buddy. And next.
We do have a question. Dr.
Okay.
Weir in Guam asks, memory consolidation and reconstellation plus PSTD. Sorry, Dr. Weir, are you there? Can you explain your question? It says memory consolidation and reconstellation plus PSDT.
It's supposed to be equal. Is that sounds to me like a definition of PSDT.
PTSD, do you mean? Do you mean, I'm sorry, PTSD?
Yeah. Post PTSD, yeah.
Yeah. Sorry. Traumatic memories are consolidated, generally not changed. So that's what kind of creates PTSD, is that when they're reactivated, they kind of bring up those same somatic feelings, sometimes the same aches and pains, the same heat. We see people who feel hot, who feel cold, whatever their trauma involved, a lot of those physical sensations come back. That's part of the PTSD experience. I don't know if that answers your question or not.
Thank you.
Okay. And Brittany says she's done it and it's amazing.
Yay! Awesome, Brittany. Glad you've tried it. Let us know in the chat where you practice, because I have actually a listserv or an email group, and I do some Zoom consultation calls once a month for people that are ART trained in Hawaii. So anyway, I wanted to bring up maybe a more applicable example. So I've been dealing with and training some folks over on Maui in ART, and someone who experienced a big fire would obviously have a very scary image come to mind before any kind of therapy. After they have some trauma-focused therapy, they might imagine fire in a more contained way. It's still there, it's still potentially dangerous, but there's something kind of walling it off and keeping you away from it. But after ART, we want people to see fire as a fun thing, as something that might be bringing them joy. So this would be an example, roasting, the idea of roasting marshmallows over the fire might be some way that someone would be able to think about fire after ART. And next. And I used a firefighter example for this because I wanted to just kind of show how ART can be amazingly helpful for moral injury, which occurs in a lot of healthcare providers, firefighters, first responders, military people, when they're asked to do something or sometimes required to do something that is not aligned with what they would like to be doing or what they think is the right thing to do. So this firefighter, you can see, is very depressed and down. Maybe something went terribly wrong, or he just feels like he didn't do the best job that he could in the fire. After most trauma-focused therapies, I changed the gender, but the idea is this person would be, pretty calm, probably able to go back to work, but at least not plagued with nightmares and that kind of thing. But after ART, we want, oh, I see. Okay. Thanks, Brittany. After ART, we want the firefighter to imagine the best possible scenario. If everything had gone wonderfully well, what would have happened? Could you have been the hero that day? Could you have utilized all your skills and really put them to work and had a much better feeling about the events of that day? And so that's the type of changes that someone could make to deal with moral injury. Okay, next. And finally, we use a part of the protocol we call intimidation buster. When someone has someone in their life that they can't change, they're always there, a toxic boss or a difficult roommate or, a family member who's driving them crazy. Instead of, you can't get them out of your life, but you can change the way that your brain thinks about them. So in this example, you would change your toxic boss to a Jack in the Box that you just kind of laugh every time you think about because it's so silly. I had a teenager recently. No, actually, she was a college student, but she changed an image of her father, who was very abusive and demeaning, into a marshmallow. And she said, "You know what? Why am I even bothered by him? He's so stupid. Like, I could just squish him. Why did I let him control me all those years?" So next. Some real life examples. Again, these are things that have actually happened in ART sessions, either myself, the ones that I've done, or things that sessions conducted by colleagues of mine that they told me about. ART is one of the few therapies that I've had my colleagues and subordinates come literally running into my office to share a recent case and tell me how fun it was or what a great insight the individual developed. Okay, next. So I know you may be wondering about the status of ART research because it's not usually mentioned when we talk about evidence-based trauma therapy. Yeah, I don't know if you can see, but this is a picture. I don't know if it's coming up. This is a picture of a provider who came into my office and did a happy dance after an ART session. Thank you. So the developer of ART, Lainey Rosenzweig, she's an LMFT. She's not an academician. She's not a professor. She works out of her living room in Connecticut. And I think for that reason, she wasn't really engaged in the type of community that would have brought ART into the research realm very early. But she kind of put it on the market, so to speak, in 2008 when she started giving it a name and doing it. In 2012, the first clinical trial, however, was published. They looked at about 80 individuals, mostly civilians and mostly older women. And they found really good evidence that it worked. So they thought, we need to look at this, look at veterans and soldiers and see how they respond. So there was a second clinical trial published in 2013. That's the one that was in the journal article on my desk. Again, very similar results. And then in 2017, a larger RCT comparing ART to cognitive processing therapy was initiated at the Cincinnati VA. Then COVID kind of hit partly into that, and so there were a lot of delays. That one is still pending publication, and we're waiting for it. But it has closed recruitment, and some preliminary findings have been released that I'm going to talk about in a second. I think I will. The third clinical trial that was published was a trial with bereavement or prolonged grief. Showed very dramatic response, not only to bereavement, but they measured PTSD indicators as well and found a really positive response to PTSD that really looked a lot like the other two trials. Okay, next. Okay, so I'm just going to show some graphs from each one. So this is the first one that they call the civilian study. And what it's showing you, that it's a strange way. Actually, all of them are depicted a little bit strangely, but the axis going up is the percentage of individuals screening positive for PTSD. They got a PCL or a PTSD checklist score of greater than 44, which is fairly high, and that was considered to be a positive screen. So the light gray is pre-ART. So they were all screening positive for PTSD before ART. And then you can see they all dropped significantly immediately post-ART, which is the darker gray. And then 2 months later, they measured them again, and that's the black. And you can see, interestingly, that sometimes the black is even better than the gray. And that gets to what I was talking about as far as the resilience building, the confidence building aspect of ART, that people often continue to do better and better because they feel better about their ability to tackle some of their triggers. The different columns there represent that, I can't read that. What was the question? Have a control? Is that what the question was?
Did the study have a control?
Correct. This one did not have a control, I don't believe. It was a cohort study, and I'm not a researcher, so I'm not that articulate as far as the way to describe the different trials, but I'm pretty sure this one did not have a control. So you can see they divided it up kind of by like age, and then by PSDQ, which is a way of measuring overall psychopathology, if you will, and then the number of traumas. And you can see that in general, the younger people did better than the older. The people with lower PSDQ scores did better than those with more, and the people with fewer trauma. Actually, no, sorry, the people with more traumas had a better response than the people with fewer traumas. So that was kind of interesting. Okay, next. So this is the military study. This one did have a control group, but the control group was not a clinical intervention. It was something like financial planning or life coaching, I think. And the reason they chose these types of controls is because they wanted to offer something other than a wait list that would be seen as beneficial to the participants, that they might feel like they would get something out of it, or they might actually get something out of it. And what it's depicting is the drop in their PCL scores. So a lot of studies use a drop in 5 points to indicate response. So they were being actually more conservative by looking for a drop in 10 points. But you can see the darker lines indicate those individuals that dropped more than 10 points. And there was way more of them on the ART group than there were in the attention control group. But the similar type of number of sessions, 4 or less, and similarly high completion rate. Okay, next. Excuse me. This is the bereavement study. I'm not as familiar with this one. I don't believe it had a control. And they showed it a little bit differently. They didn't show the 10-point drop or the grayed out part for those that didn't respond as well as those that covered the 10-point drop. But because this is a different metric too, this is the inventory of complicated grief, although they did measure the PTSD instrument as well in this study. But once again, you can see that those who did ART, had a much more dramatic improvement in their symptoms than those who did not. And again, average number of sessions was 3.7. Okay, next. So I wanted to say just a little something about the kind of high quality, what we're hoping would be the strongest trial to date, which still has not been published. It's comparing ART to the gold standard of CPT. And then there's also a waitlist control on this one. They recruited, or were hoping to recruit, 187 participants. And this was conducted out of Cincinnati, led by Kate Chard, the PI. And she also works at the Cincinnati VA. So as of October, as of this month, sorry, every time someone chats, I get a little, okay, let me see if I can do that.
I can read it to you. Don't worry about the chat.
Okay. As of this month, the data has been analyzed. The final manuscript is pending publication, but Kate Chard did present some preliminary findings in the 2022 ISTSS, which is a big trauma conference. And a direct quote from that presentation was that treatments were equal on likelihood of response, loss of diagnosis, and remission. They did note that the ART dropout rate was high, but my feeling about that, and I have no way of, I don't know for sure, but my feeling about that is that any patient that quit before 5 sessions were considered dropouts. And as you saw, a lot of times patients only need 3 or 4 sessions, and then they're good to go. And I say this because we actually opened an ART clinic at Fort Belvoir when I was there, and I gave each of my providers 5 sessions with their clients, and we would do I can't remember if it was weekly or monthly, like, consultation meetings. And eventually they said, we don't need 5 sessions. Just give us 3 sessions, because usually our folks are done in 3. If it turns out we need another one or they want to work on something else, then we can schedule it later. But it's kind of been a waste to have 5 sessions scheduled. So I think that a lot of the time, and I see this personally too, when I treat patients with ART, they have a dramatic response, but because you're basically converting these memories from really scary big T trauma memories into very benign, normal day-to-day memories, they eventually feel like, I don't think I need to keep coming in and doing this. I feel pretty good, and they don't want to do it again. So, so we'll see. That should be hopefully published in the next year or so. I'm hoping.
So the
Next.
question is, has it been studied in a rape crisis center type of scenario, a setting?
Not to my knowledge. It's only been studying in kind of outpatient treatment settings. And then that one bereavement study was done in a population of hospice caregivers. So it was caregivers of patients that were enrolled in hospice. So yeah, I mean, there are a lot of different opportunities. It's hard to get protocols approved, and I've tried to put 2 through in my career. One was actually, I think both of them were for suicide, looking at whether or not we could decrease suicidal ideation on inpatient units and get them discharged faster. But it was never approved for funding, and we didn't have the funding or the manpower to do it. So if you are interested in trying to do a study, and let me know. I think hopefully my contact information is at the beginning of the slides there. I'm happy to try and either help you or put you in touch with some people who are doing some research. I'll kind of go quickly through some of this. So basically, we had 68 trained providers at Fort Belvoir. I had them complete an online survey. You can go to the next slide. It's very hard to, in a non-research setting, it's very hard to get outcome measures, but I asked my providers to look back at their logs and try and put their patients in different boxes. So you can see the boxes range from extremely positive, meaning like one and done, no more meds needed, no more appointments needed. Very positive was like definitely made a huge impact. Eventually we're able to get off their meds, eventually we're able to dial down their therapy frequency. Positive was, definitely helped, at least as good as everything else, if not better. And then there were a couple negative or neutral and just a few negative reactions. But the bottom line was 44% of patients were estimated to have responded better to ART than traditional therapies. Okay, next. This is some of the feedback that my providers mentioned. They really liked it. They felt that it was different and dynamic. It can complement other traditional treatment modalities. Very good for children and adolescents who don't do so well with face-to-face talk therapy. And I like the last quote, talks about how actually it can improve provider resilience and decrease increase provider confidence. There was a question I saw.
Yes, here's a good question, because I wanted to ask you too.
Okay.
What does it mean to convert traumatic memories to benign ones? Obviously, you do not forget the trauma, so memory per se doesn't change. So what does change? And I want to add on this. How do you get from the memory, the more benign memory of, like, say, the person, to playing basketball with the person?
Yeah. Well, how to get from the neutral to the more positive is kind of part of the official, protective protocol. So I can't necessarily be too specific. But I mean, you just encourage them to think of a more positive way that something could have happened, or a more positive interaction that they might have had with that person. And as far as the first question, so one analogy that I was taught that I kind of like to think about is, imagine a school, gets a series of textbooks, and the textbooks are talking about something really bad in history, like a genocide or something, and it has some pretty graphic pictures in there. And they find that the kids that are learning about this event are troubled by looking at those pictures. They're really bothered. And so the school says, this is not working for us. Can you provide us with a different set or something else? And so they send them back to the publisher. the publisher, returns and gives them the textbook back, and it still has the story about the genocide or the historical event, but now it shows a picture of like the map of the area, or one individual kind of, representing that culture. So instead of the real graphic pictures, it's replaced those images with things that are much more benign. So that's kind of what happens with ART, is that you're essentially trying to replace the images, and we call it voluntary image replacement because the individual has to understand that, they may not be able to see those things, especially as well, but sometimes not even at all. And they need to be okay with replacing those images. But for someone who's dealing with like bereavement or loss, what we often say is, how would that person prefer to be imagined? Do you think they want to be remembered at their worst possible day? Or do you think they'd want to be remembered a different way, maybe a way that makes you feel happy about them or proud to have known them? And so that's kind of, maybe a little bit about how we kind of change the images. You can also change smells, sounds, even somatic feelings and stuff, which like sensations, pain, at least in the short term. So let's see, you can go to the next slide. So just some more examples from the therapists, clinicians who treated some of these individuals. This one felt that they were able to avoid hospitalization at least 2 times using an ART intervention. Let's see, the last one, I had goosebumps during the session. She went from having a full-blown panic attack at just the thought of her ex-husband throwing her down the stairs to smiling and laughing, which is absolutely, that happened to me this weekend with the training, because when you go through the training, you have to, or you're expected to work on something from your own life. And I had trainees in my classroom, laughing about what they were working on or what came up in their minds. Okay, next. I think in the interest of time, I'll skip through, but just the second one talks about this teenager that not only improved her trauma, but actually started a group at her school to empower individuals who've been bullied and abused. So that's an example of the resiliency that can develop. Next. Okay, I thought I'd throw in something more local. So we've trained 23 Maui therapists so far, and I just trained 7 Oahu Bay, actually 2 from Kauai this weekend. So we're hoping to get people trained around the state. Next. We asked them, what was your overall level of satisfaction with the training? They liked it a lot. Next. And they felt that it would be, most of them felt it was definitely be valuable to their practice. Next. We asked them what are the top 3 therapy modalities they thought would benefit the people of Maui, and 91% felt the ART should be top priority. A lot of the number 2s were EMDR, which, like I said, ART is kind of a spinoff of EMDR. And also internal family systems is very positive, was rated positively. And then 1 trainee rated ART 3rd behind family therapy and group therapy because they were working in an inpatient environment. Okay, next. This is very unscientific. I have a little survey monkey survey that I've asked our Maui trainees to complete after their session. So only 40 of them responded, but this is the type of response that they're getting in the session. So right after the session, I asked them to respond, and this is very positive right after the session. And then next slide. I also asked them to estimate at the second visit. So when the individual comes back after the ART session, how well they think the patient has improved. And you can see that even though their initial response might seem kind of neutral, a lot of them came back, at least based on the therapist evaluation, to be significantly improved in their symptoms and functioning. Okay, next. This is what the Maui providers have said. The top one I will read because it's funny. One of my clients who I did art with last Monday came back for her weekly session yesterday and explained, I don't know what kind of voodoo magic you did on my brain, but wow. She left that session with only a moderate shift in her subjective units of distress score. So that just goes to show that the impact may not always be immediate. Okay, next.
And the question is in the chat, and I have it too, is where do we find an art therapist? Is there a name, a list of them, like by island? Because I'm like, oh my gosh.
Yeah. I'll tell you about the website is acceleratedresolutiontherapy.com. And there's a tab in the upper right-hand corner that says find an ART therapist. I will say that a very small minority of people trained in Hawaii have actually advertise themselves there, partly because a lot of them are working in things like the DoD, Department of Defense, the VA, or somewhere where they just can't see everyone. You know, even Kaiser Permanente, you can't see anyone who doesn't, you know, have Kaiser insurance. Also, the search function isn't working very well. So we tested this out yesterday at the training, and only 4 people came up, but there's at least 8 of us, I think, that have a profile there. So if you can't find anyone through that site, you know, send me an email. I can see what I can do to find someone. But we're hoping to get people, you know, trained around the state. So these are some of the things, as you can see, a lot more than just PTSD that have been worked on with ART. Next. Okay. This is where I talked about eligibility. I kind of covered this already, that you have to be either a licensed mental health professional or a pre-licensed mental health professional. And those are the requirements. Grad students have to have, it's even more scrutiny. Honestly, I would not personally recommend grad students because they're learning so much as it is. They have a huge, you know, kind of coffer that they're trying to fill with information. I think it's a lot to take on, and you can actually work with clients who have pretty significant emotional reactions, you know, kind of falling apart, crying, and there are ways that ART teaches you to deal with that. But if you're not used to that, it probably would be better to wait a couple years. But technically, with the right supervision and letters and whatnot, they are eligible for training. Okay, next. So this is the slide I mentioned. I'm not trying to sell anything, but since people may have questions about how to get trained and where to go, I mentioned the website there. A lot of times organizations like clinics will find money through grants or something. I know one of our really good art therapists on the Big Island who just started with the VA there, when she was working for a community-based mental health clinic, they had some grant money, so they just sent all their providers to the mainland for training when it wasn't available here. So that's another way to do it. If you don't have enough money, maybe you can find an organization that can sponsor you. But I'll stop there. I'm open to questions. I think that was my last slide, if I recall.
That was great. And I'm
Oh,
on
good.
the website and I found a few people, so that's good.
Oh, good.
I found you. I found 4 people, but I couldn't find anyone on Maui yet. Will there be any more trainings in Hawaii? I would consider doing it.
Yeah, and my hope is to definitely do more trainings in Hawaii. Part of it is that I need to find venues. So ideally a venue would be, you know, inexpensive or free. That'd be the perfect thing. But the venue has to have a conference room for the didactic portion of the training. And then it has to have what we call breakout rooms that are fairly close by. So this works out really well if a clinic wants to get a number of people in the clinic trained, because we can just use those trainees, you know, offices for the breakout rooms. Sometimes there's a conference room available, but no breakout rooms, or breakout rooms and no conference room. And that doesn't really work. So that's part of the issue. But provided I can find venues, my hope is to do more trainings on Oahu in the spring. I'm hopeful that we're going to have some funding to do trainings kind of pro bono for, or maybe not pro bono, but scholarship-based trainings for Maui therapists coming up in the next 3 to 4 months. Yeah.
And when you work with minors, do you have to have their parents or guardians there?
You don't have to. We usually like to tell the parent or guardian what we're going to be doing, so that the patient doesn't leave the room and tell their parent on the way home, yeah, they were doing this weird thing where they waved their hand in front of my face. And we just want the parent to know what we're doing, and so they're on board. Some children that are maybe more anxious, they might want to have their parent in the room, and that can be helpful for those types of situations. And also, as the parent is like hearing what the patient is coming up with, they can really develop some great insights into their child's mind and what's bothering them, and what they're worried about. But I've done a lot of kids without parents in the room, and that works out very well as well.
Wonderful. Dr. Weir asked if a church would be a good training site, and I guess it would be if there was a main room and then multiple breakout rooms.
Yeah, it definitely would be. It's usually 3 days, and typically over a weekend, because I have, like I said, a day job. So I'm off Fridays. So usually Friday, Saturday, Sunday. So that's the only thing with the church. I know sometimes there are services over the weekend that, might cause problems, but I'm happy to, if someone knows of a church, I would love to talk to the leadership there or talk to them.
Wonderful. More questions? We do have a case, as I mentioned, so we're very excited.
Thank you.
Any last questions? All right. So shall we go to the case? Is Scott on?
Yes, I am.
Would you like to present the case?
Sure.
Perfect. Go ahead. You've got the floor.
Okay, so this member looking for help with placement or treatment ideas or options. This is a 39-year-old male who suffered from a cardiac arrest pre-hospital in January of 2023. Cardiac arrest was related to meth-induced cardiomyopathy, and he's also positive for COVID at the time. He was hospitalized from his admission on January 15th, 2023 through November 30th, 2023. He is now deemed incapacitated adult and he has a legal guardian. So as you can see, his medical diagnoses here: history of cardiac arrest, systolic heart failure, dilated cardiomyopathy, congestive heart failure, acute acquired lung QT syndrome, anoxic encephalopathy, history of meth use, hypertension, diabetes. He's had some perineal abscesses recently with genital infections related to those abscesses. For psychological, he has major neurocognitive disorder, severe delirium and behavioral disturbances, anoxic brain injury with agitation, and major depression disorder. Current services he's receiving through Quest is home delivered meals, adult daycare at 7 days a week with bathing, and then he receives incontinence supplies. His 1147 is at risk and with 20 points. If we were looking at ICF, he would only make 12 points for his 1147. Reason why: he is a walkie-talkie male. He is mobile without any assistive devices, but he's slow with his movement and actions. Really no risk for falls. Male is unaware of his age. He doesn't always have a good grasp on his surroundings. For example, he goes to daycare and he thinks he is going to school and doesn't comprehend that the surroundings and everyone's ages. Well, another example, when driving through Lahaina here a couple weeks ago, all the buildings are gone, obviously, but he still saw them. And as they drove by the former location of Taco Bell and Pizza Hut, he was insistent they needed to stop there. The family explained there was nothing there. It was all gone. And he kept on saying, "I see it right there." And he continued to get angry, a little agitated, because they were telling him it wasn't there and he could see it. He tends to be have aggressive behaviors at times, which is one of the reasons he had such a long hospital stay of 319 days. He has been doing fairly well at daycare, but tended to be a little aggressive towards his mother and manipulative towards her too, trying to guilt her into giving him more food or a cigarette. He continues to gain weight. He is currently 5'10" and about 335 pounds. He will eat, and then 5 to 10 minutes later, he's saying, "I hungry, I hungry." When told that he already ate or just ate, he tends to get angry with his family, insisting that he had not eaten. So at adult daycare in August, he started having some inappropriate behaviors, including outbursts, touching people, making inappropriate comments towards women, shoving some staff, general aggression. Adult daycare was going to discharge him from their services if his behavior did not change. Psychiatrist did increase his clozapine to 150 milligrams at bedtime and increased his Depakote to 500 milligrams in the morning, 250 milligrams midday, and 1500 milligrams at HS. And this did help curb the behaviors. His psychiatrist is considering trying Nudexa, but wanting to do some more research and consult with pharmacy and cardiology. Here is his current meds that he is on: the Bumex, Celexa, clozapine, Depakote, Premarin, lisinopril, Magox, metoprolol, Colace, and spironolactone. So has his, basically we're looking at psych and cardiology are the two medication categories. As you can see, they've tried several other different medications for his psych, and this was most of this was while he was in the hospital during his 319 days of admission, or they were trying to flatten out his behaviors. His mom, she has her own medical conditions, and that inhibits her from properly caring for her son. Plus, his behaviors towards the family is much worse than others. The family would like placement, but he doesn't qualify for long-term care, and he is under the level of care points needed. And then he is not under CCS. Ideally, he would get under CCS and be able to reside in a group home, but his diagnosis does not support admission. He has no income, but his legal guardian is in the process of filling out for disability. His legal guardian and psychiatrist are open to having this case study presented to gain on any thoughts or ideas or perspectives. His psychiatrist said, "I think the big issue or message is that he has no insight and very disinhibited and really impaired cognitive function due to his brain injuries, and which is super hard to manage." So looking for any thoughts or ideas. The psychiatrist did submit the 1157 again, trying to see if we can get him on CCS, but at this time I'd love to hear if anybody has any thoughts or ideas on this case.
Well, first, I'm glad they're filing for disability because he's definitely disabled. Dan, what did you think about his meds? Summer, can you scroll to the meds? Anything they could do there?
Yeah, Scott, thanks so much for the presentation and incredibly challenging case. Just a couple of questions in regards to the needs of the family. It sounds like mom or his mother is pretty limited in what she may be able to provide. Or are there additional resources from the community, like maybe a registered behavioral technician or something, or someone who could assist in the daycare center to provide a little bit more behavioral intervention and skills intervention when he's becoming more activated or aggressive or irritable?
I am not sure, but that's a good idea. See if somebody can work with the daycare staff.
I was curious, with major, neurocognitive disorder, usually neurology or geriatric medicine may be able to work with a neuropsychological evaluation to kind of quantify kind of the limitations of his, cognition and kind of develop a behavioral plan around that. Do we have that data?
He has seen a neurologist, but he has not had a neuropsych evaluation.
Okay, yeah. And then the
It's
other thing,
also-
Dr. Liu, I'm sorry, go ahead.
No, go ahead.
So Dr. Liu, our geriatric psychiatrist, usually when there's just so many medications that have been tried, many of them unsuccessful, sometimes he would recommend gene site testing or pharmacogenomics just to kind of get an idea of the kind of the panel of medications that the patient may not metabolize well, and try to and also look for some guidance on those medicines that he may metabolize well.
So some comments also in the chat. Foster home. A couple people mentioned a foster home that will take someone with behaviors like this.
This time he has no income, so that's a problem with the foster home.
So Andy asks if he has temporary disability through, is it BSSD? Yes. Andy, is it BSSD? Okay.
Yeah, through BSD, through the state, like the DHS office where you get welfare and food stamps from, but there's like a temporary, that office is called the BSD office, but it's the like pre-temporary disability that you would try to qualify for before Social Security.
Yes, I know what you're talking about, that like $400 and some a month.
Yes.
No, he is not on that. The family's actually just absorbing all the costs that, outside of Quest, his Quest Health Plan is paying for all of his treatment and his adult daycare, but he's living free with his family, and I have talked to them about that, but I think right now they're concentrating on just trying to get him on the disability.
And which I think is a great idea, because then he'll have more options. The genetic testing is very interesting. We had a talk on that a while back to see which medicines are more effective in him and less effective in him. And hopefully it would be able to, simplify his medicines a bit. Ricky recommends Catholic Charities has a really good webinar series, recorded and ongoing, for behavioral interventions for patients with dementia and behaviors like this. So maybe good for his parents and family to try and figure out things.
Okay.
Other ideas?
Yeah, I have a question. Are they receiving services through the island, like disabilities division, through the county and the state?
Services right now that they're receiving is through the Kaiser Quest services.
Okay, so each island should have a disability branch, and they have advocates usually through there as well, so that when he first applies for Social Security disability and then gets denied, their advocates in their office will do the paperwork usually quicker than legal aid will.
Okay, thank you.
So when he applies, okay, excellent. Well, I'll write up this and get it to you. And then let's revisit it like in a month and see if, since they're applying for disability, maybe some of the services will come to him.
Sounds good.
Yeah, and Ricky, if you know the name or link to that series, the webinar series, if you could get me that would be great. Okay.
And if anybody else thinks of something after this presentation, reach on out to them and pass it on to me.
Yes, we definitely will, Scott. Thank you for this really challenging case.
Thank you.
Yeah. And also I'll get you that, and then we will revisit it.
Okay.
What do we have on for next week, Summer? Oh,
Next
right there.
We have Aloha Kekahi'i Kekahi, the 5 love languages of grief.
Okay.
In brief.
All right. So,
Learning the best ways to communicate with your clients and patients.
all right. I'll be on vacation next week. Will you be here, Dan?
Yes, I will be here.
Thank you. All right. I'll be in New York City, but thank you, everybody. Great talk today and great discussion. Oh, there it is. Wonderful, the Catholic Charities thing.
Thanks.
All
Thanks,
right,
everyone.
okay,
And I will put that link up on iEcho as well.
great. Can you get me Scott's email too? I'll send this.
Will do. Oh, we have
Thank
one more
you.
comment. SOAR Works program trained specialists to assist with disability application.
Say that again? Oh, I'll check.
Yeah.
I get it. All right, thanks, everybody. See you next week.